Hello, and welcome to today's virtual program hosted by the Healthcare Council of Chicago. My name is Megan Phillip, and I am the Executive Director of HC3. We are a mission-driven platform proactively seeking uncommon alignment to improve Chicago's healthcare ecosystem. As we continue to navigate the ongoing COVID-19 pandemic, HC3 launched the Transformation Series to address how we can leverage our collective resources to foster solutions and help rebuild our communities. Over the past year, the coronavirus pandemic rapidly swept across our communities. It induced a considerable degree of fear, stress, and anxiety amongst many of us. Evidence has shown that levels of loneliness, depression, harmful alcohol and drug abuse, and self-harm or suicidal behavior are on the rise. So today, in recognition of Mental Health Awareness Month, we are incredibly fortunate to be joined by several leaders from organizations making a difference in the Chicago area across the state of Illinois to strengthen our behavioral health safety net. Before we dive in, I have two quick announcements. This morning's discussion will be recorded and shared on our website, www.hc3.health, for later viewing and sharing. As we hear from today's experts, if you have any questions, please use the chat function, which will be seen directly by our moderator, who will do her very best to address them during our audience Q&A. Without further ado, I'd like to welcome our panelists and moderator to join us virtually by unmuting their Zoom and turning on their cameras. Today's panelists include Judd DeLoss, CEO of the Illinois Association of Behavioral Health, David Applegate, Director of State Policy at the Kennedy Forum, Illinois, Heather O'Donnell, Senior VP of Policy and Advocacy at Thresholds, and Dr. Wanda Parker, Vice President of Clinical and Therapeutic Services at Aunt Martha's Health and Wellness. And the discussion will be moderated by my incredible friend and colleague, Mindy Clouden, who is a Senior Director at Third Horizon Strategies. Welcome all, and thank you for joining us.
Thank you, Megan, and thank you to HC3 for hosting this important event. I think that it's really a valuable time to be talking about behavioral health, not only because May is Mental Health Month. Today is the 1-year anniversary of the George Floyd death. And, you know, as we are emerging from the pandemic, we are seeing tremendous stressors on our system, the behavioral health delivery system, on our individuals and families that have been experiencing the psychological fallout, not just of the pandemic, but also the, resulting economic recession. And all of the things that we've all been dealing with in terms of isolation and feelings of anxiety. The Kaiser Family Foundation, for example, conducted a poll and found that 4 out of 10 adults had symptoms of depression and/or anxiety. We know that there have been an increase in deaths by opioid and other kinds of drug overdoses. And we also are seeing that people that already had serious mental illness are experiencing heightened symptoms, and providers are reporting that the level of acuity across the country and here in Illinois, it has really been heightened by the pandemic. So with all of this swirling around us, it's really an important time to be thinking about what are the needs of our communities and how do we address those needs. So I want to first ask Heather to talk a little bit about what are you seeing in terms of this increased demand, and how are you and Thresholds beginning to prepare to address these needs?
Well, thanks, Mindy, and so glad to be here. So I think that Illinois and the country has been experiencing a mental health crisis for decades. And it's just in the recent past that we have started to really tackle it. And I think the pandemic, combined with the racial unrest and the fight for social and racial justice, has really just highlighted what we already knew. There is not enough access to mental health treatment or substance use treatment, whether you are on Medicaid or you have private insurance, or if you have no insurance. Cook County Sheriff Tom Dart has called the Cook County Jail the largest treatment facility for people with mental health conditions or substance use conditions in the state of Illinois. Jail is not a treatment facility. It's not a therapeutic environment and can cause a lot of harm and trauma. We have in Illinois, Black Illinoisans are 9 times more likely to be incarcerated than white Illinoisans. And in Chicago and the country, Black and Latinx children and adults are less likely to have access to medication and treatment. And we are seeing Chicagoans, Black Chicagoans die nearly twice the rate of white Chicagoans from opioid overdose. And then you overlay the pandemic on top of this that is causing and exacerbating mental health and substance use. I think we just have a lot of challenges. I think the upside is that in most policy circles, whether it is in Springfield, in Washington, locally, there is a lot of focus on these issues, whether it's access to treatment, whether it's the social determinants of health, whether it is access to housing for people who are living on the streets and have treatment needs. So I think what we are seeing is what we have been seeing for a long time, and then a lot of isolation and collateral damage from that. So I think that's sort of the environment. I don't know what others think or.
Yeah, I'll back off that a little bit. I mean, I think just to emphasize what Heather was saying is that we're really facing 2 public health crises right now. The COVID-19 pandemic and an ongoing mental health and addiction crisis that's been made much worse by the pandemic. And I think we've all heard about this and seen this, whether it's through our own lived experience or professional experience, media reports, studies, polling. The trend is clear that people are dealing with significantly increased mental health and addiction challenges right now. I mean, rates of depression and anxiety have skyrocketed in the past year. We saw record amounts of opioid overdose deaths in 2020. While the suicide rate did not generally increase in 2020, it did increase significantly amongst Black Americans, which again, as Heather was highlighting, really highlights the continuing inequity that we must confront. But I think the thing is, though, that while the pandemic has exacerbated a lot of these issues, they're not actually new. This has been a part of a long-term trend. And what I think COVID-19 has really done is it's shown a spotlight on the prevalence of mental health and addiction in our communities, and then really how these challenges have gotten worse in the past year. And then when we talk about opportunities, I think a silver lining of this is just the elevated discourse and public dialogue around mental health and addiction. Not really just for just generally reducing stigma around mental health, but for an opportunity to talk about solutions and concrete actions and what we need to do to increase access to care.
If I can jump in, maybe I agree with what Heather and David said for sure. I guess I would add one other, make it a triple threat, and that would be the equity and inclusion as well then, right? So we've seen also, and I have to really kind of give ode to the providers, all of those on the front line having an increased amount of stress and depression and anxiety around the treatment, right? But still having this almost kind of like moral trauma about knowing how badly they need to be there for those who need the services, but also needing to do some self-care and take care of themselves. So we see that. We've also seen the exacerbation of those who, I've seen personally some of the people that were doing so well with their depression, with their social anxiety, and the pandemic has really kind of set them way back, for sure. And I think that it, for me at least, has also shown the gulfs in different service lines and access to services. I think it becomes more exaggerated when we have something like the pandemic happen, and how very important it is to level the playing field so that everybody, regardless of their insurance carrier or lack thereof, gets the same amount of services and the same quality of services that they need.
I would just add to echo those thoughts that in addition to obviously the tremendous negative impact upon the community and our residents in Illinois, the providers, the thresholds, the Aunt Marthas of Illinois that provide these services, in addition to historically being underfunded, tragically underfunded, there's also obviously the negative impact of COVID in terms of having to impose social distancing, not being able to see as many clients and patients as they have in the past. They have made do with telehealth, which has been a lifeline, I think, for both clients, patients, as well as providers. But historically, because of that underfunding, that lack of funding, the lack of attention to behavioral health issues, we're kind of playing catch up, and it's at the worst time possible, obviously.
Yeah, Judd, I think that's a great segue to, where I was going to try to go next, which is to say, so well before COVID, we knew that the behavioral health delivery system was problematic at best, right? Like we know that there's underfunding for mental health and substance use care in this country. We know that there's a dire workforce shortage of qualified behavioral health professionals, all the way from psychiatrists to finding licensed clinical social workers. What is the role of state policy in addressing these like seemingly intractable barriers? How do we begin to actually make a difference? And I'm going to ask David to go first on this one.
Yeah, sure. So I think, consumers consistently cite the inability to access care and cost or affordability as the top barriers to behavioral health care. And I think a lot of this is driven by inadequate coverage of behavioral health care and a lack of parity in how health plans treat behavioral health care. And I think, this manifests itself in some different ways. So, despite the clear need and demand for behavioral health care, data published, I think, in 2019 by the actuarial firm Milliman shows that health plan spending on mental health and substance use disorders was only around 3.4%. The same data set also shows that behavioral health providers, and Judd spoke this a bit, are consistently reimbursed at lower rates relative to primary care providers and other healthcare specialists, which is going to be a huge driver of our workforce shortage. Furthermore, adults are 5.2 times more likely to go out of network for behavioral healthcare needs relative to medical, surgical care, or other healthcare needs, and children are 10.1 times more likely to have to go out of network for behavioral healthcare. I think the point is that this is expensive, and more often than not, that makes care inaccessible for people. So I think, when it comes to policy, if we want to increase access, we need to, bolster our workforce, increase reimbursement rates for behavioral health providers, and lessen burdensome utilization review practices that keep providers from joining networks. I think this will go a long way towards making healthcare more affordable and making it easier for consumers to access care when they need it.
And the one thing I think that we are experiencing, we really are seeing a crisis in the workforce. We simply don't have enough social workers. We don't have enough therapists or psychiatrists or nurses. A lot of many people with the most serious mental illnesses, they have a lot of other complex medical conditions. And for a provider like Thresholds, who provides services in the daily lives of people almost every day or weekly, we also help them manage their medical conditions as well. And what we are seeing right now through the pandemic is, and I think Dr. Wanda sort of alluded to this, that there's a lot of burnout by people that are on the front lines, that have been working night and day through telehealth, sometimes still face-to-face through the pandemic. And we already had a workforce shortage, and now we are seeing staff who are just at the point that they need a break themselves, and people are reevaluating what is important to them through the pandemic and the racial unrest. And so providers on the front lines are really having a very difficult time attracting staff and maintaining staff, to the point that we are looking at potential service reductions. On the policy side, I think there is a real recognition at the state level that we already had a crisis and a workforce shortage, but now that it's immediate if we don't want to reduce services. So there are discussions at the state level for how to help providers attract and maintain staff. And I'm hopeful, but there's a huge advocacy role here in terms of payment reform to help attract, help be able to pay staff an adequate salary, student loan reimbursement, and other things, and revising antiquated rules that sort of limit what staff can do with clients. So there's a lot of advocacy going on. And even though I feel like we're a little dire on this webinar, I do feel that policymakers are listening and want to try to solve some of these real challenges.
So Judd, with your members, what are some of the solutions that you're seeking? What are some of the ways that you're looking to support the behavioral health workforce and provider delivery system?
Sure. At IBH, we're working with members like Aunt Martha's and Threshold, as well as our partners like Kennedy Forum, to come up with actions to take to rectify the immediate issues that both Heather and David had mentioned. I think that right now, the key is, well, first and foremost, I guess the first thing I should say is a big thank you to the administration. Governor Pritzker, in his proposed budget, did acknowledge that there is a need for increased funding for behavioral health, for mental health and SUD. And his proposed budget does reflect that. So that is a key first step. What we're also working on now is obviously transforming the system of care. We have a bill that would introduce a pilot program in Illinois, creating certified community behavioral health clinics, or CCBHCs. And that is a model that has been demonstrated throughout the country. It's a viable solution. It integrates both behavioral health care and primary care, creates a funding stream that is relied upon by both the providers as well as funding organizations, the state, et cetera. And we have come up against some pushback on that proposal. As I said, it's been utilized in the majority of the states in the country. And I don't want to go too deep into the details with that, but we would like to see that transformation, because it does reflect integration. Heather mentioned working with primary care issues as well as behavioral health care issues in one location. Aunt Martha's has a federally qualified health center, a very similar concept, but this would be on the behavioral health side. We're also working with our divisions of mental health and super on SUD and mental health funding, utilizing the block grant funding. Those additional funds that were made available, the $2.5 billion and $3 billion that was recently released or announced from SAMHSA, the federal source. And we're trying to develop not only the immediate addressing of needs and critical needs. We've had members that have closed their doors over the COVID pandemic period, but also looking at transforming that system into a sustainable model, one that can reflect the ability to provide care, be reimbursed at a fair level. So we've introduced the CCBHC bill, a rate equity bill with our partners as well, to raise rates, reimbursement rates across the board at a set level for the next 3 years. And then now we're working with our state agency compatriots to try to establish some type of model for building the infrastructure, developing the workforce, and then moving forward with alternative payment models, pay for performance, those kinds of methodologies.
Dr. Wanda, anything you want to add in terms of policy solutions that should be pursued?
Well, I think really Judd and Heather and David spoke to them, but I think what's important is that when we're really talking about taking it head first, the behavioral and SUD needs, and we need talented individuals to be able to do that integrated model that I know we at Martha's really believe in so much. Then where there's this bi-directional communication, and actually there's a value base in that too, right? It drives down the cost when you have that level of integration. So they actually save money in the end. So I think that, you know, there has to be a commitment to the reimbursement rates being raised so that we can have that talent there, right? There are incentives, like I love Heather, you know, talking about student loans, right? That's one of the burdens that many that actually travel that road of being a professional have to bear while providing those services. And wouldn't it be something if we were able to take that load off their back then, right? Incentivize that so that they can do more community-based services and not feel like they have to go for the heavy hitters in order to compensate for what they'll have to pay out in student loans.
David, I want to go back to you for a minute to talk about the parity issue. You know, one of the things that I have heard from payers and from providers is that they feel like the onus is really on the patient to file a complaint, right? To say when there's a violation of parity. And that's really hard because oftentimes patients don't know what their rights are. They don't understand what the parity law is. You know, what are you seeing in terms of enforcement of parity, and how do we help educate folks about what their rights are in terms of mental health and substance use care?
Sure. So, I mean, you know, first off, I think there's lots of positives and negatives here. I think, you know, a report was just published by the U.S. Government Accountability Office. I think it was at the end of April, that showed that health plans are still skirting parity laws, and this is after a decade after the passage of the federal law. So I think that just highlights it's not enough to simply pass good laws. It's really comes down to we must adequately implement and enforce them. And I think that the state of Illinois deserves some kudos here and has done a good job recently. You know, we have a very strong parity law in Illinois. And just last summer, our Department of Insurance announced the results of market conduct examinations looking at compliance with the parity law in the commercial market. They found set lots of violations, and then they fined the insurance companies, and the insurance companies that were found in violation over $2 million. You know, with that said, that was a great sign. I think the state still has more to do on the Medicaid side, which I think is important as we talk about equity, by conducting similar parity audits of the Medicaid managed care organizations to ensure there's parity compliance on the Medicaid side. And this gets to kind of your point about your question about where the burden lies. And I think, you know, yes, consumers do need to file complaints and we do need to educate consumers. But I really think that the burden should not be on the consumer to make sure that their health plan, be it public or private, is complying with mental health parity and offering robust mental health and addiction benefits. Parity is a relatively complicated law. And I think most importantly, when an individual or family is in crisis or is seeking treatment, that should be their focus. It should be on getting better. So they shouldn't have to worry about whether or not their health plan is going to pay for care. So we need to educate them on their rights, but we also need to, I think the government can play a role here, and government regulators can really have an impact by actively enforcing the law and actively protecting consumers, so they can focus on what they need to focus on, which is getting the care they need and getting better.
Yeah. So you mentioned folks that are in crisis. I think this is a really good, you know, segue to talk a little bit about kind of the crisis system. And, you know, we recently at the federal level, they created the 988 new crisis line for behavioral health. And a lot of states, including Illinois, are now looking at how does that get implemented. When you all think about kind of crisis care for folks that are having a mental health or substance use crisis, what needs to change there? And how do you see the creation of 988 impacting the system?
I can try to kick us off. This is a huge, huge issue. The potential, well, the 988 line as an alternative to 911 for people in a mental health crisis is just an enormous opportunity for Illinois. But at the same time, we we do not have any of that infrastructure in place. Thresholds does provide crisis response services, and we have partnerships with the Chicago Police Department. We've been working with the Chicago Police Department for a very long time. And I think we are literally in the infancy in Illinois of developing a crisis system that responds or attempts to respond to both children and adults, hopefully regardless of insurance, which I think is extremely important. We do have pockets of crisis services, but nowhere near what we need. So we are just looking really forward to working with the state to how to make this happen. At the beginning of this discussion, was talking a little bit about the intersection of the mental health system with the criminal justice system. And oftentimes, well, we've really just defaulted to having police be the first responders to mental health crises. And we have all seen time and time again how that can lead to really terrible tragedy. We really should have mental health and substance use professionals responding to crises where someone's life is not being threatened. And I think that 988 is an opportunity to do that, with the caveat that I think we need to be mindful of the practical challenges, and that this is going to take years to build.
Oh, I think Heather froze. Yeah, so, it can't just be a crisis line. There has to be a follow-up system, right? There has to be what happens when you call a crisis line. Judd, what would you like to see?
Well, as part of the planning process with the Division of Mental Health, there is obviously a very rushed attempt to address these new requirements and new needs that the 988 system is imposing. And I don't mean to make that sound negative, because it is a positive, as Heather mentioned. It's a great opportunity to really refine the system, to devote it, dedicate it, and focus it in on those in need, to work to transition from that kind of criminal justice response or law enforcement response to these situations, to have those that are trained and specialized and can provide not only the immediate assistance and treatment that's necessary, but then focus and be able to assist the individual that's in crisis and their family members to treatment providers for a longer term impact. So rather than having police involvement, emergency room involvement, which is timely, it's time consuming, it's expensive, you have those types of providers that are specifically trained to be able to address these needs, and then get these individuals into the treatment system where they're going to flourish, rather than be stuck in an emergency room, or worse, even in a jail. So I think that's the opportunity we have, but it is it sort of snuck up on us. The 988 system was dropped, and there's some very short timeframes in order to get this planning process and the development of the framework in place. So it will be an uphill climb, but I think providers are definitely dedicated to seeing it to completion.
Yeah, and I would say that, it's a beautiful thing to know that we're at that place, because we have plenty of data to reflect that we need a different system then, right? And that we have seen so many lose their lives or not get the access that they need as a result of it. The other piece is that I think that it goes hand in hand with us being able to continue telehealth services and supporting ongoing mental health services and access to those things in a very quick way, right? Whether it be by telephone or by video, that there can be intervention crisis in those modalities as well. We do crisis intervention, and you're right, being the police being the front line, there's whole infrastructure change, really providing level of training as it relates to those. We already have the data to reflect that we know that many have mental health and SUD issues. use. And so we're not really kind of reinventing the wheel. That part is done already. So what do we do with that information then? Really prepare people to really have a soft approach to folks that are in crisis then, right? Who don't have resources. And when we talk about equity and inclusion, who are hopeless then. And even when we talk about, I know we were talking earlier about parity then, if I have to choose between trying to fight for my life because I'm in crisis or fight for parity, then, you know, which one do I choose and which route do I go, right? And I may not know how to do either one of those then. So I think resources get pushed in the wrong direction when we say that they have to be able to fight for those things. We want them to fight for being well. And if our system is really a system of health and wellness, then it should really foundationally and infrastructurally support that then, and not create a system where people have to work off of a deficit in order to get what they need, right?
Yeah. Heather, welcome back. We were continuing the conversation about.
Sorry about that.
No, no worries. Glad you're back. We were continuing the conversation about, you know, what needs to happen with the implementation of 988 and kind of following up on crises as they come in. You know, there are examples around the country. Cahoots in Oregon is one. STAR program in Denver, here where I live, is another example of programs where they're sending behavioral health professionals out in lieu of police. Did you have more that you wanted to share about that before you were cut off, Heather?
I think we need a variety of different models. I think we need mental health and substance use professionals that go out instead of the police. I also think we need co-responder models. And then in some circumstances, I think it is always important to have a backup when a police response is necessary, but that should not be the default. So I think there are models out there, like you mentioned, that we can follow. And then there are providers working and doing this now in different varieties around the state. So I think we need to explore all these options.
Thank you. So let's bring this down to the city level. You know, when we think about access challenges, it's really the most dire on our most underserved communities. And, you know, when you think about what needs to happen within the city of Chicago, Dr. Wanda, I'm going to ask you to speak first to, you know, what do you see as solutions? Well, first of all, what do you see as kind of how the most vulnerable communities are experiencing behavioral health crises? And then what do you see as the solutions of what we need to do to address these?
Well, I think what we've seen all the time, we see now, but it's more magnified, right? It's about access to care then. And without having those resources, you don't. But I also think it's really, and one of the things that I know the mayor has in her plan, which I think the spirit and the vision is the same, but how we go about doing it is what I actually think needs to be different. We have to broaden the net as far as access then. And so if we want to know, we know that telehealth works. There's some social determinants of health that are remedied in being able to provide access in their home, not having to deal with the mental labor of going in. Some people are just not going to go into facilities to receive care. And in the mayor's plan is some more home-based services, which is great, but this pandemic has also told us that we need some other access as well, right? Because it's not always feasible to do that. So being able to provide telehealth, but also providing those vulnerable populations with the technology that they need in order to be able to access those services, much like someone who has more resources would be able to do with their smartphone, with their iPad, with their laptops. Being able to have that level of access for things like behavioral health, but also continued monitoring of the PHQ-9 score, self-administration that will remotely go right to your providers so that they can monitor those things, that they can do Columbia suicide screens for those that have high PHQ-9 scores or expressing some level of suicidality. Then that type of technology right now has been reserved for those who have the resources for that to happen. But when we talk about really kind of leveling the playing field and dealing with disparities, that everybody should have access to that type of service where they can get better and not be in some ways prohibited to because they don't have the access or the resources. I think the other piece is, and I think we have to be honest about the fact that if insurance is about healthcare and healthcare is about health and wellness, that we have to also address some of those other social determinants of health, and the food deserts that exist. And think about when we went into the pandemic and how people couldn't get tissue, let alone vegetables and meats, and some people who don't have transportation to travel to or resources to travel to other areas, how that inhibited them. And those are things that I feel like all those things that really kind of divided those who have resources and don't became magnified during the pandemic. And so my question is, when we have the data, then I guess the same question that I asked before, what do we do with that information then? So I think that also trauma-informed care is important. A lot of kids that go to school that have hard times focusing and really being functional at school may not be because they have ADD or ADHD. It may be that they have had trauma exposures. And so really, how do we train everybody in trauma-informed care? That means in the healthcare centers, the receptionists and all. We've taken on that challenge, Aunt Martha's, to train all of our staff in a trauma-informed model because you want everyone to look through that lens. I had a client probably about 6 months ago say to me that he has never felt so cared about than from the providers that were treating him. And that to me was important. And he didn't say in a healthcare system, he said period. And so I think we have to think about the populations that we serve then and the resources that they may have or may not have, that sometimes we are a very important role other than just a provider of those services then, right? We actually provide another benefit to their life, and they actually learn to trust us in ways that maybe they haven't trusted healthcare providers or service providers before. So being able to open up the access, I think, and not to have it just for a pandemic, but to understand the value that is added and that we need to have it as a standard model of care is my thought.
And I just want to echo, I think you hit the nail on the head with a lot of what you, Dr. Wanda, just articulated. One of the things that we have seen in the pandemic related to the social determinants of health, so thresholds cares for people who have very serious mental illnesses, severe schizophrenia, severe bipolar disorder, and our service model is not an office-based model. We work with multidisciplinary teams of social workers, psychiatrists, and others, and we go out to the individuals where they are to support them in their home. And sometimes that entails seeing them daily and weekly. And during the pandemic, in certain areas of the city, you could go outside for face-to-face visits. You could go sit outside at a coffee shop or a McDonald's or at a park. Well, a lot of neighborhoods on the south and west side, there aren't a lot of safe places to do that. So people living in those communities didn't receive as much face-to-face visits. So I think that in terms of city level policy, just addressing the social determinants of health. And the city can't do that alone. Obviously, this is not just a city issue, although the question dealt with local advocacy. But I think we need the city of Chicago and the state to work very closely together on all of these issues, because while many of these issues are local, and all politics is local, quite frankly, the bedrock of the public mental health system is Medicaid, and Medicaid is really a state federal program, but the state drives Medicaid policy. So the city needs to work really closely with the state and vice versa to address some of these social determinants and expanding access and being able to help providers get trained in trauma-informed care, and also doing a lot of outreach in communities where maybe traditional treatment the individuals are not necessarily ready for traditional treatment. So street outreach to get people off the streets and stabilize their lives, and then provide them an on-ramp onto more traditional treatment once they're ready. Those are some of the things that I think we would recommend. And we are doing this at the city level and sometimes funded by the city. Through Thresholds, we're actually developing a young adult team to reach out to young people who are at the early stages of a serious mental illness and living on the streets. So there's a lot of opportunity at the city level as well.
Agreed. I just to echo again some of those thoughts. One of the issues that Heather mentioned and Dr. Parker mentioned was Medicaid and then the deserts. And one of the issues that had been raised fairly recently during the pandemic is the issue of accessibility to pharmacies and how the Medicaid program had designed access to pharmacies and the inability for a number of citizens to be able to access those pharmacy services within the city of Chicago and the West Side. And so through the advocacy of many, that has slowly started to change. There's legislation that's been introduced, hopefully that will address that. But I think on a bigger scale picture, as Heather mentioned, Medicaid is the primary funder here. And how Medicaid reimburses, how Medicaid structures its reimbursement is an issue so that providers can get out there and serve these, the most vulnerable population. One of the things that I did note today in the news was that throughout the pandemic, obviously providers and individuals have been dramatically impacted negatively. I mentioned that we've had a few of our members that had to close their doors. And obviously there have been other negative consequences as well. One of the things that was announced just today in the news is that the Medicaid managed care organizations made record profits last year. 3 of the MCOs had roughly a $300 million increase in their profits last year, and that's not even including 2 of the larger MCOs. In response, my understanding is HFS is going to allow those MCOs to retain those profits until a routine audit and accounting is conducted in 2023. And I frankly, I'm not going to step up on a soapbox right now, but I don't understand that. There's hundreds of millions of dollars that should be in the hands of providers that are providing those services, or at least in the state coffers to help balance the budget. But it's being held by the Medicaid managed care organizations instead of being utilized for what it's intended, and that's providing those services. So I'll stop there.
Well, and Judd, it's likely that some of that has to do with the medical loss ratio, right? Like there weren't as many services being provided, so they weren't spending as much in reimbursing providers. One of the ways, Absolutely. Of course, that over the past year and a half that providers have tried to continue to reach patients has been through telehealth, right? There's been an exponential growth in the use of telehealth in the behavioral health field. I mean, behavioral health providers dove right in. They were one of the first, types of providers to be providing care in this new way. And now, as we're kind of emerging from the pandemic, there's beginning to be a lot more discussion about how do you blend this model with more traditional service delivery. What would you all like to see in terms of continued telehealth flexibilities, a blended model of care, and what are the kind of the unique things about treating people with behavioral health conditions that have to be considered as we think about the future of telehealth? I'll direct this one to Judd first.
Sure, thanks. And yes, I do acknowledge the medical loss ratio. I think I was speaking more in terms of timing of that recoupment of those hundreds of millions. But on the telehealth front, I think behavioral health is ideally suited for telehealth utilization. And we've seen that, my understanding that on the commercial side, the huge increase in the use of telehealth, 90% of that was in the behavioral health space. And the same goes for Medicaid managed care. Both Medicaid managed care and commercial insurers are 100%, as I understand it, devoted to continuing behavioral health telehealth services and providing what they call, and this is a different type of parity, payment parity. So parity in the sense that services that are provided in person are reimbursed and reimbursed at the same level as telehealth. So there's an equality there in terms of how much reimbursement is paid for both providers and coverage for the individual. If they receive telehealth services, it would be exactly the same as if they had been treated in person. So I think that's one of the big issues for me. I know that others, especially David, have been very deeply involved. So I'm going to defer to them on some of the other areas that telehealth needs to be addressed.
I'll jump in. Yeah, I mean, I think telehealth, to use the word again, I think has really been a silver lining in the pandemic. Its use as a means to access care has obviously increased exponentially during the pandemic. And I think the feedback from both patients and providers has been overwhelmingly positive. And I think, the Kennedy Forum, we think it's vital that people are able to continue to use telehealth as an option to access care, even as we move into this post-pandemic world and kind of implement some of these hybrid models. But in order to be able to do that, we have to put in place strong public policies that make telehealth a viable option for consumers. And so as Judd mentioned, I think first and foremost, we must have payment and coverage parity if we are to expect providers to deliver care using telehealth and for patients to be able to afford that care. We must have parity in how health plans cover and pay for services delivered via telehealth. So this means that insurers must adopt equitable payment and coverage policies that reimburse care delivered via telehealth in the same way it's the same rate and basis as when it's delivered in person. Another thing, though, is I think, one of the primary benefits of telehealth is the ability to receive care regardless of physical location. So care can't be conditioned, coverage can't be conditioned on the location of the patient or the provider. And patients in particular must be allowed to receive care from a location that they feel is safe and comfortable. And then I think, lastly, I mean, the digital divide is very real, and it's a big problem that needs to be addressed. I'm certainly not a telecommunications policy expert by any means, but I think obviously we need to increase broadband access in Illinois. And I think that's something this administration is actually trying to do. But regardless, I think when it comes to the technology that we use for telehealth, we must meet people where they're at. And recognize that unfortunately many don't have regular access to a computer or tablet or smartphone, and they might have limited minutes or data. So as long as privacy is respected and health and safety are ensured, I think it's important that kind of as the last piece, policies must allow for maximum flexibility in the type of technology used for telehealth. So for example, allowing use of like audio only for people who don't have access to a computer or a tablet or a smartphone.
I think one of the things that we talked about before is the need for more providers. And so we have to have a way to be able to provide those, to pay for those providers. And I think the other thing is that the service, whether it be in person, via video, or by telephone, is the same service. And so while I believe that the MCOs made money because of the medical loss ratio, I also think it's because people had access to some additional services that they didn't during this time, with some suspension of some of the regulatory guidelines. I think the other piece is that wouldn't it be great if some of the money that they gained during that time, that they reinvested it in technology for those vulnerable populations then, because it wouldn't just help for them to be able to access behavioral and SUD services, which are some of the more expensive services that MCOs have to pay out, but it also would cause for them to be able to have access to them for their complex care coordination and their care coordination of services too, to be able to make sure that they had that wraparound, right? That integration that we always talk about, which everybody is entitled to, whether or not they have the resources. And when we really talk about leveling the playing field, it's being able to give that level of value and quality care to people who have Medicaid. Why does Medicaid, get the short stick, right? So being able to have that kind of quality care, I think they still would see some of those profits that they got if we're able to do that in a very meaningful way and provide services to people and access to resources that they don't have, and extend that menu. It's not just about providing behavioral health SUP services, but those social determinants of health. How can we help in that area? Because if someone doesn't have a stable place to live, everything really kind of goes to hell then if you don't have that right. You're not going to follow up with your medical, your behavioral health, or your SUV services. And if you don't have food to eat, then it's going to be difficult for you to follow through with anything else. So they really are a package deal. And I think when we break it up and we divide it and cut it out as a separate thing, that we do a disservice and really approaching to kind of eliminate some of those barriers that exist for those folks.
I love that idea of using that money to invest in some of the things that we're talking about. That's exactly what we ought to be doing. The one thing I want to say about telehealth is that particularly for substance use services, medication assisted treatment, that was not available unless a client was on site at a facility before the pandemic. And it radically changed telehealth radically changed access to medication assisted treatment for the clients that we serve. We do a lot of street outreach. And so you can get somebody connected to medication assisted treatment immediately when you connect them to the primary care physician that is going to be the prescriber. Whereas before they would have to make an appointment, and sometimes that window of catching somebody when they're ready to engage in substance use treatment is so limited. You want to get them through that window as quickly as you can. So that has been enormous for our clients. The one caveat that I think that everybody has talked about is that it's not just the digital divide, it's the technology divide. Most of our clients have experienced a lot of homelessness. They live in severe poverty. Their only income source is disability payments, and oftentimes they have a government issued phone that does not have video capacity, or they have limited amount of minutes. And we also learned through the pandemic that while telehealth was sometimes the only way to connect with somebody for treatment, for people that have really, really serious conditions, they didn't have the kind of presence in their lives that regular face-to-face visits provided, and they suffered as a result, not necessarily because of their mental illness, but because they just didn't have that support in their daily lives. So telehealth should always be an option if that's what the client wants. But at the same time, for many people, face-to-face is going to be crucially important as well.
And I think it's important to acknowledge that a lot of what mental health and substance use treatment really consists of is helping people to build relationships, right? To feel connected, to feel that sense of I'm part of a community and I bring value to my community, and kind of recovery principles, right? Mm-hmm. On the other end of the spectrum from what we've been talking about, I think is, how do we build resiliency? How do we help people to prevent mental illness and substance use conditions from either manifesting or becoming exacerbated, right? So in these last few minutes, what are your thoughts about what needs to happen in terms of prevention and getting upstream for behavioral health? And I'll go to David first.
Sure. I mean, I think, you need to get in front of it early, and often that requires investing in the treatment system and getting into communities and making sure that care is community based first and foremost, and getting to people early. And I think, when we talk about stigma and discrimination against people with mental health and substance use disorders, there's a big part of that that's about our culture, our social norms, and about people feeling comfortable seeking care and knowing it's okay not to feel okay. And I think that's really important. And I think we're really continuing to make progress in that regards as we see more and more public dialogue around mental health and addiction, effectively normalizing it and making folks know that it's okay to get treatment and reducing the stigma that oftentimes surrounds and prevents people receiving treatment. But I think, there's another part of it that is really about structural stigma and structural discrimination. And that's a lot of what we talked about today. In 55% of people with mental illness don't get treatment. 90% of those with the substance use disorder don't get the treatment they need. So I think solving that problem really requires strong public policies that ensure care is affordable to consumers on the front end, and that we're really investing in our treatment system and our behavioral health workforce. And then again, just the ongoing theme that we're always working to increase access, particularly in vulnerable communities, so people are just seamlessly able to get the care when they need it and that they know it's okay to seek it.
And a couple of public policy initiatives aimed at that are in the process of being success stories. We passed a couple of bills in the last couple of years. One is the Early Mental Health and Addictions Treatment Act that would create multidisciplinary teams for young people in their teens and 20s who have early signs of a more significant mental health condition. These kinds of teams are more geared today towards adults who have really advanced mental illness. And we really need developmentally attuned teams to help young people understand their condition, stay in school, stay resilient, and provide them the wraparound support. And the other piece that we accomplished through the Children and Young Adult Mental Health Crisis Act is prevention services through Medicaid. Right now, you cannot get through a community mental health center, you can't get mental health counseling treatment unless you have a diagnosed mental illness and you go through a lengthy assessment. We all know that kids experience so many things that, for instance, trauma or divorce or LGBTQ issues, bullying, where they don't have a diagnosed condition and they really just need support for whatever circumstance they're going through. And Illinois is in the process of putting that in place through the Medicaid program. So there are some things that we have accomplished that are in process.
And I think that for people to be comfortable to state that they need mental health services, are going through a mental health crisis or substance use, that we can't have it both ways, right? Because we can't say that we want you to do that, but yet we have stigma related to it. So if someone has a substance use issue, then they can't get pain medicine or can't be referred to a pain specialist, right? Or that if they have mental health issues, that there's going to be a cap where you might have to fight for those services that you need due to Parity. I mean, we can't have it both ways, right? People are not going to be as open about their mental health and SUD service or seek out the services that they need if there are all these barriers that exist in them getting them, right? Or what's the point of seeking out services that aren't available or accessible to me, and revealing your soul and some of the most intimate and crisis moments to someone when you won't get the help that you need. So we have to make services accessible. If we really believe in that, then we have to really create environments. That means in school systems for kids to talk about those things that they need and not be labeled, right? And be able to have an environment where people feel open to do that and won't have any repercussions then for being able to share that they need that help.
Yeah, I echo those thoughts. I think prevention is critical right now as we come out of the pandemic, hopefully continue to do so because of what every teen, every child has been exposed to during this isolation period, the increased reliance upon substances, legalization of cannabis. So a large number of IEBH members are very much keen on prevention as a primary mission or their sole mission. IEBH itself operates its own prevention programs as well. And I think that those are going to be critical as we move forward.
Well, this has been amazing. I think we could definitely use another hour, but really want to thank you all for all that you do and for coming with us today. I know Megan wants to have the last word.
Thank you, Mindy. And thank you all so much for sharing your time and your expertise with us. We're super grateful. To you, Dr. Wanda, David, Judd, Heather, and Mindy, thank you for leading this important discussion. The recording and recap for this event will be available on our website under Insights over the next few days. The second installment of our Safe Return to Care event is coming up on June 10th at 12 noon. So for anything on everything HC3, you just go to www.hc3.health for our future events and all of these great recaps. But thank you all again for your time, and I hope you have a wonderful day. Thanks.